Vitreo diseases 2, and this is the finals of this session. So I would request the speakers, if they are present, to load their presentation already and be ready. We will start with Sandeep. So Sandeep will present his first paper in this.
Can you load Sandeep Reddy?
Iram Tandal is there. Next one. Next speaker.
I'll be presenting. Next speaker is there. Okay, I'll be presenting on functional structure correlation of retinal ganglion cells. Yeah. So the aim is this is an observational study where we are trying to understand the topographic correlation between the retinal ganglionic cells to retinal nerve fiber layer at the disc with the help of the OCTs. The thickness values of ganglion cells and calculating at the circle using the various. So, what is the role of OCT in advanced cases of glaucoma, established cases of glaucoma, and in glaucoma suspects? So, that will be the basis of the study. Basically, what's in the first, we should understand how exactly the nerve fiber layers actually pass through into the optic disc. The papillomacular bundle, they take the central part. This is the temporal. For example, this is the right eye, where the papillomacular bundle enter the center, and the macula, these are the macular fibers, and these two are for the peripheral fibers that enter the optic disc, and these three are the nasal fibers. So basis on these findings, what we understand is, whenever you have a thickness of around the optic disc, the nerve fiber layer thickness, it falls into the red zone only when the thickness falls to 80 microns in the inferior and superior quadrants, while in the temporal and the nasal part, you can see in these areas the red starts only at the thickness falls below 45 microns, and the redness and the papillomacular bundle falls into redness only if it falls less than 30 microns. So on this basis, if you actually see various, and this is the picture of the ganglionic cell at the macular area, which is called the GCC. So GCC corresponds to the visual 10 degrees visual field. In that visual field, if you take the various thickness, you can see the red falls, the redness starts around 65 microns, and it falls up to about 40 microns. So even by the time this the GCC falls from 60 microns, the patient might not develop scotomas in the visual field. For example, if you take these slides here, you can see these are two patients here, where the sectorial GCC thickness has fallen down to 47 and 46, and the patient has complete absolute scotomas. And you can see when the thickness is about 72, the patient does not develop much of a scotoma, while the patient has, and this is the papillomacular bundle. So in this patient, if you look at the visual fields and the GCC, the papillomacular bundle, even the thickness has fallen down to 40 microns, still the patient has some amount of visual field. But when it falls to 48 and the superior and inferior halves, you can see there are absolute scotomas. When you look at these two pictures here, the scotoma that the visual field the patient has looks very similar. Okay, so what we see in these patients are both the patients have a similar scotoma in both the eyes. But when you actually look at the GCC, the papillomacular bundle is severely affected in this eye, where the thickness has fallen down to 56, and if there is any fall further because of glaucoma, the patient is going to end up to have an complete absolute scotomas. While here, though the visual field is lesser than this, the patient is much more resistant in developing defect in the GCC. So what is very important, even though visual fields show you large scotoma, the very similar scotomas, unless you don't do GCC, you cannot tell what the patient exactly has. So how severe the thinness has gone to. So if you look at these patients here, the scotomas look very similar, and the scotomas have fallen down to the thickness has fallen down to 55, and is the patient even in the inferiorly when the thickness is around 55, the patient still has a good vision. The same patient, if you look at the scotoma here, the patient has 90 and then he does not have any scotoma here. So in these patients, though the visual field look very similar, these patients you have to be more aggressive, while compared to the patients where the GCC is much better. So in these patients, what we proposed a name called perimetric glaucoma in the superior half. So these are some of the examples where the patient has developed almost kind of absolute scotomas. Inferiorly there is a loss, and superior field is completely lost, and the patient is very much resistant. Are much more safer in the superior half. In the similar way, the patients, the loss in these patients is very severe. You can see the GCC losses very severe in these patients. Yes. So what is very important is, even the patients have very severe disease. It is very important to do GCC in every patient of glaucoma to evaluate the scotoma, whether the scotomas are deep or superficial. Even if there is severe retinal fiber loss, sometimes it may not be appreciated on the visual fields. So GCC can help us in evaluating a glaucoma case. Thank you.
It's not a study actually, but it's just a case where we had a rare presentation which came up. So I have no financial disclosures. So it was about a 36-year-old male who presented to us with gradual progressive diminution of vision since 2 months. He was a known case of chronic myeloid leukemia since 6 years, and he was on treatment with imatinib for the last 6 years. So the last blast crisis which was noted in him was 3 years back. He was also tested for Philadelphia chromosome, which was positive. He did have a BCR-ABL gene positive before, but the last evaluations, everything was negative as of that time. The ocular examination, the right eye had a visual acuity of 1/60, and left eye was 6/6. The rest of all the anterior segment evaluation was okay. Now when we come to the right eye fundus photograph, we can see that there is presence of a yellowish subretinal around 2 disc diameters of subretinal lesion, and which is admixed with some subretinal as well as intraretinal hemorrhages. Along with that, we can see there are some pinpoint hard exudates that are noted. The periphery of the fundus was normal. There was no evidence of any kind of vasculitis or anything of that sort. The other eye was normal, and I'll be just sticking to the right eye for the next of my presentation. So you can see that the OCT showed that there is presence of an macular edema with subretinal hyperreflectivity that was noted with subretinal fluid also, and most important, we can see there is hyperreflective dots that are lining the subretinal fluid cavity. So we went ahead and did the fluorescein angiogram of this patient, and we can see that initially the hypo lesion slowly started to come out to have an hyper, and it was leaking, and the corresponding hypofluorescence were corresponded with the hemorrhages that were seen clinically. This is the FFA depicting the very same. Now here we are at a diagnostic dilemma. At that time, an OCT angiogram was not was not done for the patient. Now, is this a CNVM, or is it just a leukemic infiltration that is present with a reactionary edema? So just based on our FFA findings, we decided to treat it as an CNVM, and we went ahead and planned an Avastin as and when required. So post first dose of Avastin, absolutely no change in the fundus, and neither the OCT was any helpful for us. So at this time, when we are thinking like, okay, we revisited our diagnosis because no absolute change in the interim we asked the patient also if he felt any change. He didn't. So are we dealing with a leukemic infiltration? What was the thought that had come to our mind? And we said that should we shift to an IVTA? So what at this time, the patient is already on Avastin, the patient is already on imatinib. So we decided that now let's add an IVT and see whether is it a leukemic infiltration or not. And to our surprise, after the first dose of IVTA, you can see that the yellowish subretinal lesions are starting to resolve, and as well as the hemorrhages are starting to resolve. So this is the OCT post 6 weeks, and the angiogram also was surprisingly very. Sorry, it's a red-free photograph, so it was very better than before. So again, we repeated the same for the patient, but this time we decided to give a cocktail of medications because we are still not sure whether it's a CNVM or whether we are dealing with a leukemic infiltration. But we erred on the side of leukemic infiltration also because it showed a good response to IVTA. Now, just for discussion, why can macular neovascularization occur in an CML cases when you have these leukemic cells? They secrete excessive vascular endothelial growth factor, and they are known to have macular neovascularizations. The second thought what we had was, why not an leukemic infiltration? Because it has been shown that imatinib in itself will hamper the VEGF secretion. So now a patient who already is on imatinib and who already is on anti-VEGF injections, right? Why should not it be an leukemic infiltration? So we still are not very sure about what we were dealing with, but just a general last slide that I will share, that if a patient of CML has an ophthalmic manifestations, probably early screening would help us, because they are reported to have lower 5-year survival than those without. Thank you.
That was a nice presentation, Dr. Rudvij Pandya. Do you think is there any causal association, or it is just a finding between these two?
So that's what we were trying to think, that whether it's first of all whether we are dealing with CNVM or whether it's a leukemic infiltration. At that moment of time, we actually we didn't had an OCT angiogram to actually show us a new vessel, but just a retrospect, we are going all through our cases of this all CML presentations. This was a dilemma. What we thought that what are we dealing with? We are not very sure whether it's an whether it's a neovascularization or whether it's a leukemic infiltration, because the patient has already been on imatinib since long, and it has been shown that imatinib they are proposing treatments as an as an adjuvant or a second line to anti-VEGFs also, though very early, but it was there. So we are not very sure about that.
ICG has not been tried?
No, not at that time. This is all in retrospect. When we were thinking would another what thought process we had in our mind was, are we dealing any opportunistic infection also that is causing over here also?
Looks very much like a CNVM, but idiopathic CNVM.
Yeah.
Can't say anything. And it's a nice presentation.
Yeah, thank you.
Is Iran candle is there? No. So the second speaker is not there.
There is a new technique of snowfall technique of vitreous staining. It's a triamcinolone in acetonide in the infusion bottle. No financial interest to disclose. So conventionally, we know triamcinolone we are using in and out for all our retina cases for staining. It is used for anterior segment surgeon also, and we regularly use triamcinolone acetonide as a suspension directly injected in the vitreous cavity. But then this is a different way, because when we directly injecting, we have some pros and cons. So we thought of doing something different changes where it will give a better result. So this is vitreous where we have put a triamcinolone in the infusion bottle compared to directly single injection before starting vitrectomy. So in our 9 routine cases, usually we take a triamcinolone what is available commercially, keep it for half an hour, remove the superficial fluid, and we put this directly the remaining suspension into the infusion bottle, and then we do a routinely vitrectomy. What we have observed compared to triamcinolone, when we put it directly, we get a good staining and then suddenly gush of triamcinolone. Compared to what we put in a BSAs, you not see that much of staining. but it is a continuous flow of triamcinolone which is giving a continuous staining throughout your vitrectomy in the fluid procedure. Also for the base excision and everything, it is giving a good visualization in the periphery. So this is a conventional what we see when we inject a single directly either in a routine case or even in a Meckel roll or ERM. And that is uncontrolled. Sometimes we really don't know, and then it just become a stain over in the posterior pole. There is hardly, after once we remove, hardly we get any stain in the periphery. So that's how we see the snowfall coming up, and then so here we are seeing a infusion bottle directly from the cannula. We are seeing continuously the triamcinolone particles are coming and then staining throughout the procedure. We can do practically all stage including PVD from periphery and then core vitrectomy and then base excision. So it gives a continuous staining procedure available throughout the surgery. So there was no complication related to the technique. Initial case selection were very simple cases of ERM, macular hole, cataract surgery, complication or diabetic. A compulsory fluid air exchange to remove all the residual triamcinolone, and no post-operative reaction was observed. In fact, I were much quieter compared to the normal what we are using. So these are the few references. Thank you for your kind attention.
Do you always need a vitreous to be stained, or how is it like?
No,
All the cases you do?
I do most of the cases now. So that gives a good visualization for me.
But once you've identified your the
Not
vitreous.
all the cases now, but then especially for macular hole ERM where I just need a good base excision and everything, periphery also I am doing routinely.
Okay, but the only thing is, once you've identified and you've taken off, you've done your vitrectomy, after that still there'll be a snowfall of.
Yes. So initially, because we are just judging how much the amount of triamcinolone we required. So initially, when I taken the few initial cases, it was more flow coming up. Over a period of time, I have reduced the amount of triamcinolone I put in the infusion bottle. So that helps to it just give a very continuous flow of the triamcinolone coming up. So that you can decide how much the particles you can really actually want to put in the infusion. So how much you want to put actually into the infusion bottle.
But you leave the fluid again. It's a fluid filled dye with triamcinolone, which is.
No, normally it's air or silicone oil or a
Okay.
gas.
Okay.
So very interesting, Dr. Shah. What did you also check the intraocular pressures post-operatively, and
Yeah.
and how long? I mean, these 9 eyes that you've done. How long have you checked the intraocular pressure post-operatively? I mean, immediately post-operative, and then after a
So
couple of
these are
days.
patient which I started from last year. This is almost more than 1 year follow-up, and then now I still do a lot of cases because now you don't require every cases, but then sometime in a chronic cases where you are doing a resurgery, where we have done some other cases in macular hole ERM also, because when I'm seeing if there's any residual vitreous remaining, so I
Did
still
you
do
see
it.
intraocular pressure spikes after
No, I
these
have
such
not
cases?
seen.
Because I would personally be scared because that leaving so much of
Gas or the oil, because once we do a fluid air exchange, hardly any triamcinolone particles are seen.
Is that much of triamcinolone is enough to stain the posterior vitreous?
So as I told you, because staining is slightly inferior, but then when we are doing initial or single injection, you just in a central part, you are not doing any periphery. Here we are doing a good peripheral staining also.
Dr. Rakesh, have you ever operated in aphakic size with this kind of a technique, in aphakics or pseudophakics where the PC dehiscence is there?
Yes.
So is there any chance that these deposits go into the chamber and anterior chamber and the trabecular meshwork, and then later on they can cause?
Over a period of time, as I told, because I have used the quantity of triamcinolone used is quite minimal now.
But once the entire chamber,
But then I have not seen any
steroids.
IOP spikes coming of anything over there. right
And
now.
one advantage is also that even if you leave some tricot into the anterior
Because
chamber,
that in fact eyes are much quieter compared to my normal
the
cases
inflammation
over
will be
here.
much lesser. Even if they
Yes.
get deposited, they
Yeah.
will disappear in a week's time.
So rather than glaucoma, in fact, number of post-operative
won't, it
steroids
won't.
are because not
Generally, it won't.
yes.
Even if they get deposited in the angle,
In
they'll
fact, one thing
disappear.
what I have added now is along with the triamcinolone, I just put a 1 drop of Reti-Blue also. So blue dye also in the infusion bottle. That gives
Chrome
additional
vitrectomy.
visualization.
Chrome vitrectomy.
Yeah. So because otherwise vitrectomy has become routine for some
But
change.
one's use of triamcinolone essentially is to aid PVD induction in the first place. So what we saw was you cutting the peripheral vitreous. So at that stage, it's not really that essential. But for most people, it's PVD induction, making sure that your vitreous, all the chytic vitreous, you're getting all the layers over there. So how is the staining
No,
of
because
the?
sometimes because in the peripheral because it's the visualization becomes so easier to remove it, and with the 10K cutters and everything, because I find it become much faster for me because visibility was very clear. I don't have to do a base indentation and everything because it's just continuous flow was coming in and I could see these all staining at the vitreous part.
Lovely.
Thank you.
Do we have anybody else? Any of the presenters sitting over here? Can you tell us your name, doctor, and come?
Good evening, everyone. My paper is on OCD-guided evaluation of anatomical and visual outcomes of various types of diabetic macular edema. The presentation has no financial interest. The project has got approval from SRC and IEC. Epidemiology of diabetic retinopathy. Globally, 93 million people are having diabetic retinopathy, out of which 21 million have diabetic macular edema. In India, 6 million people are with sight-threatening diabetic retinopathy, and diabetic macular edema is the leading cause of diminution of vision in diabetic retinopathy patients. According to WESDA, the prevalence rate of macular edema in diabetic retinopathy population is 10%. And definition of CSME. CSME can be defined as retinal thickening within 500 micrometer of the center of the macula, or exudates within 500 micrometer of the center of macula if associated with retinal thickening, and retinal thickening of size 1 disc diameter or larger in area, any part of which is within the 1 disc diameter area of the center of the macula. Even though there are various classification systems for classifying diabetic maculopathy, in our study we have used OCT classification. In OCT classification, can be classified into spongy macular edema, cystoid, taut posterior hyaloid, neurosensory detachment, and mixed. And the biomarkers for diabetic macular edema include central subfield thickness. CST is alone is considered in the study. The other biomarkers include hyperreflexive foci, drill, ISOS junction abnormality, choroidal thickness, OCTA, thickness of vascular plexus. Aim of the study is to evaluate the anatomical and visual outcomes of various types of diabetic macular edema following anti-VEGF injections. And the objective is to classify different types of macular edema in the study sample, to evaluate the visual outcomes using best corrected visual acuity, and evaluate the anatomical outcome using CST on various types of diabetic macular edema post-injection, post-anti-VEGF injection. The sample size calculated is 100 eyes, and the inclusion criteria is all diabetic macular edema patients consented for the study, and the exclusion criteria include the patients who have already underwent anti-VEGF injection, the patients with tractional RD, and the patients with macular edema of non-diabetic origin. And methodology, it is a prospective interventional study. In this study, study period is from July 22 to 23, June 2023. The patients who were diagnosed with CSME, who underwent anti-VEGF injection, were studied using OCT and Snellen chart and were followed up for three injections, that is 4 months. And the results included, out of the 100 eyes obtained from 68 patients, 62% were males. And on age distribution, the most common age group was more than 60 years, constituting 42%. And the patients were given, 72% of the patients were given ranibizumab injection. And on OCT-guided classification, the most common type was found to be cystoid, constituting 40%, and followed by spongy, which constitute 34%, followed by mixed, 26%. On in patients with moderate NPDR, spongy macular edema was the most common type, and in severe NPDR, cystoid was the most common type. And on assessing the visual outcome using the mean best corrected visual acuity converted to logMAR scale, in spongy type, the pre-injection mean BCVA was 0.397, post-injection was 0.25 with an improvement of 0.147. In cystoid, an improvement of 0.167 was found out, Both corresponds to 1 Snellen's line improvement. In mixed type, a 0.245 improvement was found out, corresponds to 2 Snellen's line. On an average of an improvement of 0.187, that is slightly more than 1 Snellen's line, has been observed. The mean CST measured in spongy before injection was 334 and post injection was 252 with an improvement of 82. In cystoid, an improvement of 147 was observed and mixed 199. On an average of 143 micrometers improvement reduction in CST was observed. On comparing the anatomical and visual outcomes, it has been found that the maximum reduction in CST and the maximum improvement in best corrected visual acuity was found in mixed type. So we can tell that there is a modest correlation between the reduction in CST and the improvement in best corrected visual acuity. Coming to the conclusion of the study, the most common type of macular edema which was found out was cystoid, constituting 40%, spongy 34%, and mixed at 26%. And the mean CST reduction of 143 micrometer was noticed after 3 doses of anti-VEGF, and mean best corrected visual acuity of 0.187 on logMAR scale, which is slightly more than 1 Snellen's line, was observed. The reduction in CST has modest correlation with the visual acuity improvement in diabetic macular edema patients post-injection. And since the reduction in CST is not truly correlating with the amount of visual improvement, other parameters like drill and hyperreflective foci should also be studied. Thank you.
Basically, you have evaluated more of spongy retinal edema and cystoid macular edema.
Sorry?
So you have evaluated between the spongy retinal edema and the cystoid macular edema.
Yes, sir. The patients who were diagnosed with CSME was under OCT examination was done, sir, and they were classified, sir.
No, with NSD, with neurosensitive detachment.
Sir, that in mixed variety, cystoid or spongy with NSD was included in the mixed variety, sir.
So, is there any difference between patients with NSD and CME?
Sir, in NSD, sir, post-injection,
No. I'm talking about the basic pathology. When do you get NSD and why do you get only CME without NSD?
Sir, NSD has more of inflammatory etiology, sir. And
So basically what happens is NSD is only seen at the foveal area, right? It's only seen subfoveally, nowhere else. Have you ever really observed? NSD only happens at the subfoveal area.
okay, sir.
Okay. Why? Because fovea is avascular. The only route of fluid that goes out is only through the RPE. There are no vessels in the center.
Okay, sir.
That's why all the fluid that accumulates in the center only can go through the subretinal space. So that is why NSD happens. So NSD refers to lot of fluid that is coming into the center.
Yes.
Only CME, no NSD, can be very acute cases or chronic cases. So NSD shows you that it has been there for a little time, not too much of a time.
Okay.
It's not that inflammation creates NSD, non-inflammation does not create NSD. NSD shows that exudation is very high. Okay, that is the meaning of it.
Thank you.
Any speaker, any more speaker? What's okay?
Good evening, everyone. I'll be presenting on an experience with ranibizumab biosimilar Oseva. So we all know that anti-VEGFs have transformed the management of many retinal diseases, but the innovator molecule is less affordable to many patients. In fact, in this era of biosimilars, we have a tug of war between the innovator molecules and the biosimilars, and the reason being the cost of the innovator molecule. So what are these biosimilars? They have a comparable efficacy, safety profile, and duration of action with the original molecule, and this has led to the worldwide acceptance. Now the patent for the innovator molecule is limited and for the limited period of time, like for Lucentis, which has already expired last year, and Eylea, which is just about to. So this in fact has opened gates for the further development of biosimilars. So India was the first one to come up with the biosimilars under the name Razumab, which was first it was introduced long back in 2015. And after that, the list continues. We have Rani Eyes, Rani Zurel, and the newer one, Oseva. And only recently, FDA has approved Biovis and Cimerli as the other two ranibizumab biosimilars. So we have already did a study of Razumab, the CSER study, which we have published, and it has shown favorable outcomes in the patients of DME, CNVM, and RVO. So So we continued with our investigations and also experimented with Oseva, which is a near biosimilar of ranibizumab. And the Central Drug Standard Control Organization has granted approval for its manufacture. So the purpose of our analysis was to evaluate its safety and efficacy in patients with DME, CNVM and RVO. It was a retrospective analysis done between July 2022 and September 2023 in treatment-naive and previously treated patients of DME, CNVM and RVO. We included 37 eyes of 29 patients, both male and female. Now let me discuss with you few cases. So this was a male patient with the AMD. With a single injection, we can see that the SRF is significantly reduced with contraction of the CNV complex. Another patient with DME with NVG, which showed a significant improvement and resolution of the cystoid spaces. This was a hypertensive male patient. With a single injection, we can see there is vast improvement in the SRF along with improvement in the cystic spaces. The vision is vision is improved to 6/6. This was an uncontrolled hypertensive female patient, again showing significant improvement in vision from 6/60 to 6/12. This is the patient which has improved its cystoid spaces and normal foveal contour has been maintained. Another patient with significant improvement in the vision as well as the DME. Another PDR patient which was treated with multiple injection also showed improvement with Oseva. So we have seen that many patients actually showed good result. In this chart, we have summarized the subfoveal retinal thickness pre and post injection after the period of 1 month of all the 29 patients. And in this chart, we have summarized the logMAR BCVA pre-injection and after 1 month of all the 29 patients. And we saw that there was significant reduction in the subfoveal retinal thickness over the period of 1 month, along with improvement in the visual acuity. So also, no patient developed any of the ocular adverse events like intraocular inflammation or endophthalmitis or choroidal or retinal detachment, and no systemic adverse events were noted. So the Oseva compound was considered safe. I would like to add that real-world outcomes with anti-VEGFs, they do not correspond with the clinical studies. The Luminous study, which was the real-time observational prospective study, has shown that only up to 47% of patients actually take the recommended number of injections. So this real-life scenario is very much different with the RCT recommendation. And the main reason is the cost of the innovator molecule. So in this table, we have summarized that yearly treatment expense, including the cost of the injection, the treatment expense, the consultation and the emerging charges by the use of biosimilars can be decreased by 40%, which is a huge relaxation for a common man's pocket. In the end, I would like to conclude that biosimilars should be promoted, and the whole purpose is to bring the cost of the molecule down so that it is available to all, which will lead to adherence of the patient to the treatment, ultimately leading to the improvement in the visual acuity and benefiting the patient. At last, Oseva is safe, efficacious, and pocket-friendly drug to the patient. Thank you.
I mean, all the images that you showed,
Yes,
very good results. But then they just happened with one injection.
So, as the committee claims, like the effect should be for 4 weeks. So yes, we followed the patient for 4 weeks or the 1 month, and the pre and post images were at first day 1 or the pre-injection and after 1 month. So yes, it was for 1 month. All the images were we are still collecting data of these patients. So these are the only few pictures which I have added. We have more also. So
Okay.
just single injection has worked its wonder.
Yeah. Then it becomes a wonder drug. One injection settling down, I don't know. Diabetic RVO also, BRVO, tributary vein occlusion. But single injection, all of them settling down, good.
DME also you've seen the same results.
Sorry?
DME also you've seen the same results.
In DME patients, multiple injection at 1 month interval was needed. So, like my main purpose is to promote the biosimilars. Like in those patients which cannot be treated by innovator molecule just because of the high cost of the drug, we can shift them or give them an option of biosimilar.
Thank you.
Thank you.
Saloni Joshi.
She has two papers. Let her finish.
Good morning, everybody. Today I'm going to present the study which I did for my thesis in two parts. The first one is comparison of optical coherence tomography features in patients with central serous retinopathy versus controls. CSER is an idiopathic detachment of the neurosensory retina. It is the fourth most common retinopathy after ARMD, diabetic retinopathy, and BRVO. And it occurs because of pathophysiological changes at the Reicher's complex, which is RPE, Brooks, and choriocapillaries, which is the Haller's layer. The CSER is the archetype of the pachychoroid spectrum. The term was coined by Varro et al. In 2013. And EDI-OCT enables us for a detailed cross-evaluation of the choroid and its vasculature. The aim of my study was to compare optical coherence tomography features between patients with CSER versus normal controls. The primary objectives were to compare the choroidal thickness in treatment-naive patients coming for the first time and compare it with normal controls, and to compare anxiety scores between patients and controls. The secondary objectives were to study the other OCT features pertaining to CSER and to compare the basic demographics in CSER versus normal controls. It was an observational case control study. 100 cases presenting to retina services at Arvindai Hospital, Pondicherry were recruited after taking informed consent. And the controls were patients presenting to general unit at the same hospital. We took controls as less than grade 2 cataract and with no fundus pathology and having refractive error less than 2 diopters. They were age matched and gender matched. After taking consent, history, and basic demographics, preliminary examination was done, and EDI-OCT scan was done for all patients and controls free of cost. The OCT parameters noted were choroidal thickness, pachychoroid, subretinal fluid, pigment epithelial detachment, hyperreflective foci, and fibrin. I'll present the demographic results first. In my study, 87.5% were males and 12.5% came out to be females, thus reinstating the fact that CSER is more common in males. Whereas since we took gender-matched controls, 86% were males and around 14% were females amongst controls. The average age in cases was 39 years, and in controls, age-matched controls were taken around 40 years. For cases and controls, both the maximum population came from the rural area. The choroidal thickness was maximum for the cases as expected, which was 448 microns, and it was also high in the fellow eye in cases around 398 microns, and for controls it was within normal limits. Choroidal thickness more than 350 microns was taken as pachychoroid. So for the CSER eyes, 94% of the patients fell under this category, and 76% of the fellow eyes fell under this category. We also compared other OCT features, SRF, PED, fibrin, HRF, which were significant in CSER eyes, whereas in fellow eyes, only PED and HRF were found. CSER is because of hypopermeable nature of the choroid, which causes a breach in the retinal pigment epithelium, leading to the hallmark features. It is also responsible for increased thickness in fellow eyes, thus reinforcing the importance of follow-up for both the eyes. In my study, no correlation was found between age, gender, systemic history, and choroidal thickness. And no correlation was found between SRF height and choroidal thickness. To conclude, the fellow eyes also had a thicker choroid, thus reinforcing the fact that pachychoroid is bilateral. The need for normative database is important, creating a platform for further research. And importance of awareness of various disorders in the pachychoroid spectrum is needed for targeted management. These are my references. Thank you. The second part of my the second part of my thesis study is comparison of anxiety scores in patients with central serous retinopathy versus controls. Central serous retinopathy is of two types, acute and chronic, and the acute type variant has more depression scores. Many risk factors are involved, but stress and type A personality is most common. Stress can also be a consequence of sudden visual loss, which leads to considerable psychological distress. The older studies state that personality characteristics like overachievement, competitiveness, perfectionism, and impatience are related to stress and CSER, whereas newer studies state that emotional instability and insecurity are related to CSER and stress. The aim was to compare anxiety scores between patients with CSER versus normal controls. As stated earlier, the objectives were to compare choroidal thickness and anxiety scores and to study OCT features and basic demographics. We took 100 CSER cases, 100 controls which were age matched and gender matched. After taking consent history, basic demographics, anxiety scoring was done in these patients. The scale used was Hamilton Anxiety Rating Scale, which was a validated questionnaire, and it was administered by a trained study coordinator. So this Hamilton Anxiety Rating Scale contains 14 symptoms, and it is divided into 4 categories, namely mild, moderate, severe, and extremely severe. In our study, around 25% of patients came under the mild category, 47% came under the moderate category, and 21% came under the severe category, and only 7% had very severe anxiety. This is an image showing the 14 symptoms taken in the Hamilton Anxiety Rating Scale and 4 categories. In controls, anxiety was not present in 99% of patients, only 1% had moderate anxiety. So digging further into this, we also compared every symptom pertaining to each category. For example, this red line belongs to anxious mood. It is present in around 9% of mild anxiety patients, in 20% of moderate anxiety, in 46% of severe anxiety, and 23% of very severe anxiety. Similarly, all other symptoms are also color-coded. This graph contains the remaining 8 symptoms. As you can see, cardiovascular, GI, and respiratory symptoms did not have much impact, as they were absent in most of the patients. CSER is because of sympathoadrenergic dysregulation leading to release of norepinephrine and beta endorphins, which alters the choroidal blood flow and permeability. Conrad et al. Also stated that low emotional intelligence and coping mechanisms are related to CSER, since these patients have poor adaptive responses, and all these things are more commonly seen in acute cases. These patients tend to be more insecure with higher levels of frustration and anticipatory anxiety. The hypothalamus pituitary adrenal axis, which is regulated by corticotrophin releasing hormone, is responsible for rapid and strong responses to stress, also causing the release of cortisol. The anxiety levels do not differ whether it is the first episode of CSER or a recurrent episode. In our study, no correlation was seen between anxiety scores, demographics, loss of visual acuity, and choroidal thickness. To conclude, various psychological risk factors contribute, while stress is considered as most common. The stress hormones cause dysfunction in choroid and RP, leading to subretinal fluid accumulation. CSER is a multifactorial disease which calls for a multidisciplinary approach and proper psychiatric counseling. Thank you.
Thank you, Doctor. Wonderful slides, though. Thank you.
So I'll be just talking about my experience with fibrin glue to close retinal breaks successfully in complex retinal detachments with silicone oil in situ. So fibrin glue has been used in ocular surgery for corneal purposes, and it has also been used in simple retinal detachments where it was used to obviate the need for tamponade. It was used to close the breaks, and then oil and gas was not required. However, it has not been reported for complex retinal detachments where oil is retained. So we had this patient who had a failed retinal detachment surgery for complex PDR. Oil was already in the eye. So we thought we have nothing to lose anyway, she will be losing her vision. There was an open break which was causing this. So after little bit membrane peeling, we put fibrin glue to close the break, and there was an immediate retinal reattachment with minimum positioning. So encouraged by this, then even a long-term follow-up, she's doing well. The retina is attached, there is no inflammation, intraocular pressure is normal, and the glue is not visualized within few days after surgery. So encouraged by this, then we in complex PDR, we started using it where we could not do laser to close the breaks. So as membrane peeling proceeds, it's common to have iatrogenic retinal breaks which get covered by blood. Attempts to remove this pre-retinal blood were unsuccessful. So after fluid air exchange and drying the retinal surface, these two retinal breaks were treated with the two components of fibrin glue which are injected sequentially. First, the blue top thrombin is injected, which is less viscous, and then you see these clots. These disappear by the third post-op week, and the retina is attached and the glue is not visualized. Similarly, a second case, again bleeding during surgery, which is not allowing laser for the breaks. So the two components of the glue, fibrinogen and thrombin, are injected sequentially, one after the other. Preferably the more viscous one should be injected first, but either can be injected first with good results. So this is again a third case. Here the break was very close to the macular center, so laser was avoided, and we injected the two components of the glue. There was inadvertent excess injection, but that does not matter. Post-operatively, you see the first day the break is closed, and by 6th day the retina is attached, glue is gone. So then we started extending the indications, and this is a most of the macular hole RDs we can do an ILM peeling and the retina detachment can settle down, but sometimes we are not able to do an ILM peel. So this was a resurgery for a macular hole RD, and we injected fibrin over the macular hole. So both are closed and attached. Similarly, old RD with a macular hole. So the hole is closed and retina is attached, and within 6 days the glue is gone. Another patient, here the hole did not completely close, but at least the retina got attached. What we saw in this patient in the first post-op period, through the macular hole there is subretinal glue, as you can see the track. And within 10 days we can see that track has become atrophic, subretinal atrophy. So this is a word of caution that when we are injecting it for macular holes, probably it will cause atrophy around the hole and affect the vision finally. So this is the first time we could document atrophy at the site of subretinal glue. So it's good for peripheral breaks at least, but probably not for breaks close to the macula. So it can be a useful adjunct in the management of complex RD, especially when laser is not possible for breaks due to bleeding, edema, or proximity to macular center. Glue is not seen very early in the course, there is no adverse effect with silicone oil, and need for post-op positioning is significantly reduced because the break is already closed. Instead of waiting for the laser effect to come, which takes 3 weeks. So before that itself the break is closed immediately. So tamponade effect is not required. So positioning is not required. Thank you.
Ma'am, in the first case that you mentioned, you put glue under oil, madam. The first case.
Yes,
which
yes.
was not.
Oil was
So
already in.
Okay, you can put the glue under the oil also.
Yes, I did it in
The
that
same thing.
case. Though ideally the surface is supposed to be dry, but in that case we put it with the oil already there.
And what if there is a retinal hemorrhage over the break? Can we put over the retinal hemorrhage, but doesn't work probably?
No, you can. I think you can.
We can
because the break, the blood will go away, and then this
yeah,
will still be
this
there.
will stay.
Can we have the other mic on, please?
Yeah, mic on, please.
Any case of intraocular inflammation following
No, not at all, not even one.
I used for one failed macular hole case, I tried doing that, but I had a very severe post-operative hyperpion and all that. Maybe I used gas, maybe the entire
No,
thing came
see,
into the anterior chamber.
patient might have allergy or hypersensitivity to it. It's a biological material which is not in itself, it is not toxic to the eye. It is not toxic to the eye, but the patient may have individual patient may have allergy to it. So that may be the reason you had this.
The immediate post-op day I had, but within 3 days everything got cleared with the topical steroids. But somehow I was very scared to use it again and so often.
I've used it in many cases, no problems.
Not even had no reactions the
No.
next post-op day, ma'am. Absolutely.
Sometimes if you excess injection is given, it may go and collect as in the anterior chamber. But that's
Because the control is so difficult under air, the one drop you have to put
Yeah,
in,
yeah.
that is not easy to happen.
Yes.
Sometimes it slips. So much of fluid goes inside. Once it goes inside, once it forms a
you
clot,
can't take out, yeah.
you cannot take it out.
No,
It's all
so
stuck.
what Dr. Mudit is doing is he's using his viscous fluid injector. So that is a controlled injection. It's a particular pressure at which it goes. It's automated. So it goes drop, and he can stop with his foot switch. So that's one. I use a 2 cc syringe because that gives more control than a 1 cc syringe. And
He uses a 2 cc syringe and not a 1 cc syringe. ma'am.
not one, because one is longer. The tuberculin syringes are longer, so control is less. 2 cc is smaller. I've not had a problem of lack of control. You just try it out
No, even
outside.
that one drop makes a large clot,
Not really. You might have
It's
injected
like-
more thinking that it is one drop.
maybe.
You saw those cases. It's
Yeah.
not like that. But possibly what happens is it gets blocked outside after some time. So now if you have not first expressed it outside, you are going in with a blocked needle, and then you might put excessive pressure, which causes an sudden. Yeah. So before you go into the eye, each component you have to inject out. Eject some outside, so that the needle is not blocked when you are in.
Ma'am, how much into the periphery have you tried?
I mean, I did not have to go much peripheral because most of these were PDRs.
Okay.
But as peripheral as you can see, you can go. And the safety is more. The more peripheral you are, the more the safety, because the macular toxicity and whatever. But I showed one case where we saw subretinal atrophy. So I think
Yeah, that's
macular
in the
holes we have
macular
to be
hole.
very careful. We may not get the vision. A hole may close, but vision may not be there.
Thank you, ma'am.
Thank you. Thank you.
any other speaker other than
You
Shreyas?
don't say.
Any other speaker?
Other speakers other than
If there is no, then yeah.
Dr. Shreyash.
Good evening, everyone. Our study is on multimodal imaging characteristics and treatment outcomes of retinal capillary macroaneurysms. So we all know that microaneurysms have a size less than 125 microns. They have capillary origin. They occur usually in clusters and are associated with other retinal vascular diseases like diabetic retinopathy and vascular occlusions. On the similar lines, we have these retinal capillary macroaneurysms which have a size more than 125 microns. They also have a capillary origin, but they are usually solitary. They may or may not be associated with other retinal vascular diseases. With this background, the objectives of this study was to assess the imaging characteristics and treatment outcomes of retinal capillary macroaneurysms. It was a retrospective case series. So even though after 2018 this entity came into limelight, we routinely screen for the patients for presence of RCM, especially in patients having chronic edemas. We included only patients in whom the confirmed diagnosis of RCM was made after careful clinical examination aided by OCT and fundus fluorescent angiography. We excluded cases where it can be associated the other conditions which can have macroaneurysms like Leber's miliary aneurysms, Coates disease, etc. So retinal capillary macroaneurysms were defined by presence of orange-red retinal lesions clinically, and on OCT they'll have an oval structure with size more than 125 microns, and important is no direct communication to either retinal arteries or veins. So clinical profile of the patients was studied, fundus photo was documented, fundus fluorescent angiography was done to know the angiographic characteristics of these lesions, OCT macula cube and OCT 21 line raster was done to know the OCT characteristics, and response to various treatments were also studied. So we studied 8 eyes of 7 patients, 6 were males and 1 was female. Mean age was 62 years. Best corrected visual acuity ranged from 6/6 to 6/60 depending on the macular involvement. 6 patients had diabetes, 2 patients had hypertension and 1 patient had chronic kidney disease. These were the fundus characteristics of our patients. So to summarize the fundus characteristics, they were solitary in almost 75% of the patients, and 2 patients had multiple lesions. Most of the lesions were located in the posterior pole around disc and macula. They were exudative in almost 75% of the patients and non-exudative in 2. All the lesions had a orange-red lesion appearance. So they had surrounding retinal hemorrhages in 5 of the patients. Visible retinal thickening was noted in 3, and hard exudate ring or clusters were noted in almost 75% of the patients. Coming to the associated retinal vascular pathology, 1 patient did not have any retinal vascular disease. Almost 75% of the patient, that is 6 patients, had diabetic retinopathy and 1 patient had BRVO. So these are some of the fundus images of our patients. So coming on to the OCT characteristics, all the lesions had a oval structure. Average size was around 314 microns. They extended from RNFL to outer layers. They had a hyperreflective wall, as you can see in the picture, with non-homogeneous variably reflective internal contents. Surrounding retina had cysts, schisis, neurosensitive detachment, hyperreflective dots and hard exudates. RCM as a cause of macular edema was attributable in 3 out of 8 patients. So these are some of the OCT pictures of our patients. So coming on to the angiographic characteristics. So in almost 75% of the patient, the lesions were hyperfluorescent with minimal leak. Hyperfluorescent lesion with no leak was found in 1 patient. So similarly again, hypofluorescent lesion, as you can see in the second picture, was found in 1 patient. So this is a patient with hyperfluorescent lesion but no leak was observed. So coming on to the treatment outcomes, in 1 of the patient we tried anti-VEGF but there was no response. This patient responded very well to focal laser. So most of our patient observation was also done where it was away from the macula. So in almost 4 of our patients, focal laser led to complete regression of the lesion. The slides are not moving. Slide is not moving. Don't put it onto slideshow, just put it on PPT only. Just 2 more slides. It's not moving. Don't put on this thing. Come out of the slideshow. So this is one of our patients who had a lesion just adjacent to the disc, and this patient had poor response to Avastin. 4 weeks after focal laser, there was complete regression of macular edema as well as the lesion. So this is another patient who received IVTA treatment. Even though there was reduction in macular edema, there was no reduction in the size of the lesion or the perilesional edema. So this patient also we did focal laser and there was beautiful response to laser treatment. This is another patient with a perifoveal RCM lesion. 8 weeks after focal laser, there was complete regression of macular edema as well as the lesion. So these RCMs are also known as by various names like telcaps, macro, microaneurysms and EVAC-like lesions. OCT is best to detect these lesions, followed by ICG and FFA. They can be a cause of chronic macular edema. For non-exudative RCMs, observation is a best modality. For exudative RCMs, selective focal laser based on the literature also suggests that it's one of the best modality of treatment. If the lesions are very close to the fovea, we can consider intravitreal either steroids or anti-VEGFs. However, multiple injections may be needed. Thank you.
This is a very good.
Sir, that is what I want to say. These lesions are actually very resistant to anti-VEGF treatment. For IVT steroids, they might respond, but the response is usually partial, but they respond very well to focal laser.
So what is very important is clinical evaluation in a CSME. You have to look for these microaneurysms.
Yes, sir. So
when you have multiple microaneurysms, they don't respond to anti-VEGFs.
Anti-VEGFs.
The first line of treatment If it is center involving, you have to go with intravitreal steroids, followed by focal treatment.
Focal laser, yeah.
If it is little away, if the microneedle is little away from the fovea, then go ahead with focal laser. They respond beautifully.
And they also actually reduce the burden of repeated anti-VEGF.
So what is very important is when you're doing an examination, CSME don't go by the OCT and decide about whether you want to give an anti-VEGF or steroid. Look at the patient, look at the fundus picture, or do the examination. Make sure there are no microorganisms.
Yes,
If
sir.
there are too many microorganisms, it anti-VEGFs will not work. And among the anti-VEGFs also, Avastin and Lucentis have a poor response. Aflibercept has better response to these lesions, but obviously it is much inferior to Triamcinolone.
How do you decide when you identify RCM whether it is leaking or not leaking?
Sir, again, there are sometimes like you can do angiography also, and also we can actually identify that perilesional edema, sir. If there is perilesional edema, probably it's an exudative type of.
By OCT
lesion.
itself, once you see,
you can decide on it.
Very, very good presentation and thought provoking.